Hi, this is Raj Mehta, and I'm continuing part 2 on our topic of insulin and diabetes management in the hospital setting. And in today's discourse, I'm going to briefly go back over DKA and HHS, which I didn't review last time. Before I go into that, though, there was one brief question someone had last time for me, which I didn't address, which was about converting between different types of insulins. And that question was, how do you convert someone on, say, Humulin 70/30 to then a daily dose of Lantus? So the calculations can be a bit tricky. So let's say we had a patient who was on 40 units BID of Humulin 70/30. How much daily Lantus dose would you want to give them? Well, this is actually kind of easy because their total daily dose of insulin is 80 units. And we know our basal rate we want to give is half of our daily dose, so half of 80 would just be 40. So we just want to put them on 40 units of Lantus. So whenever someone's on any kind of combination insulin, don't get confused, don't get worried, just add up what their total daily amount is, and once you know the total daily amount, your long-acting or basal dose is always going to be half that. And conversely, when you're converting back, you can kind of do the same thing. If someone's on 40 units of Lantus, and then they're on like another 30 or 30 units of prandial insulin, their total daily dose is 70, and so then if you're going to put them on, say, Humulin 70/30, you could just give them something like 35 twice a day. Alright, let's move on to DKA. Now the key thing to keep in mind when discussing DKA is that DKA is really about reversing acidosis, and our goals are to restore intravascular volume, correct tissue hyperperfusion, and restore insulin sensitivity, because they're going to have a high level of insulin resistance when they're in DKA. And again, we want to reverse acidosis. A lot of people think reversing DKA is about reversing the hyperglycemia or getting the sugars down, and although that's an important management of DKA, our goal is always acidosis. The three main components of treating DKA are fluids, correcting electrolytes, and obviously our insulin treatment. And although we're not covering it very in detail in our lecture right now, it's always important to keep in mind that whenever you work up someone's DKA, you're obviously going to be doing your history, your physical exams, ordering labs as listed here, and if you want to, you can check a serum beta hydroxybutyrate. I rarely do that, but this is the ketone that is in your ketoacidosis in DKA that you can measure directly, and will show you the severity of your DKA. Now, just to briefly go over a few electrolyte concepts. First of all, people in DKA will often have pseudohyponatremia. What this means is that when you have really high glucose values, then your reported sodium is actually lower than your true sodium. And you can use this formula that I've listed here to find out your true or corrected for hyperglycemia sodium. And someone, let's say, who has a glucose of like 1,000, and this is common in HHS, and a measured sodium about 140, your corrected sodium may actually come out to something like 165, and you may actually be hypernatremic. So it's worth keeping that in mind and correcting for it. The other reason it's important to correct your sodium value is if you want to find out your water deficit, your formula listed here depends on you knowing what your true or corrected sodium is. Now, I don't always calculate the water deficits whenever I'm taking care of my DK patients. On average, it's usually around 3 to 6 liters. And the important thing to keep in mind is that when you're treating them, you want to bolus them with fluids, and you don't want to hesitate. You can give 1 to 2 liters of bolused fluids in the first to second hour, and because they have such a huge water deficit, it's not going to be a problem. When you're doing your fluid management after your initial bolusing, you want to put them on either normal saline or half normal saline, and your rate can vary from 250 to 500 depending on how aggressively you want to hydrate them. A lot of times when patients aren't responding to insulin therapy, it's because they have hyperperfusion, and you want to increase your fluids to make sure that insulin is getting to those receptors in the periphery. The next thing always to keep in mind with your electrolyte treatment in DK is that a lot of times patients are going to have significant potassium depletion. The average dehydrated DK patient has about 500 milliequivalents loss of potassium that you have to give back to them. Now, when you first take care of a DK patient, they may actually be hyperkalemic because acidosis causes your potassium to go up. And if it's greater than 5.5, you want to make sure you get an EKG and they're not having abnormalities. Once their potassium begins to drop below 5.5, you can start replacing IV fluids as listed in the chart here to give them potassium with their fluids, and so that you make up for the fact that their potassium is going to start going down once you're giving them insulin. Okay, let's move on to actually giving insulin in DK. Now, the first thing to be aware of is that people in DK are going to have decrease sensitivity to insulin. So you want to start off by saturating the receptors of the body with tons and tons of insulin, that when you start treating them on their insulin drip or infusion, it will start working. And this is why we usually begin with giving them a bolus of insulin calculated at 0.15 units per kilogram, and after we do that bolus, we start them at an infusion rate of about 0.10 units per kilogram an hour of our infusion drip. Now our goal when we start our infusion drip is to decrease our glucose of about 50, sorry it's not written here, to 80 grams a deciliter an hour. And this is the rate you want to keep it between. If it's less than 50, you can titrate your insulin up. If it's more than 80, you can bring it down. And the reason you want to keep it in this value is if you do it too rapidly, you risk potentially having cerebral edema, which you want to avoid. And if you're doing it too slowly, you're not going to be able to reverse your acidosis in time. As I mentioned before, you are not treating hyperglycemia and DKA. Your treatment goal is reverse your ketoacidosis. To measure this, I usually get a BNP about every 4 hours just to make sure their bicarb is improving. You know your acidosis has resolved once you meet these parameters here. Let me scroll down a little bit. Basically, we usually look for a bicarb greater than 18, and I should say greater than 18. And usually I want to get to the 20s before I feel like I'm out of DKA. You want your anion gap to be less than 12. That means your acidosis is resolved, and your pH should be greater than 7.30. Now, one thing to keep in mind is that as you're treating DKA, most of the time your sugars will get down to the 200s, but your acidosis will not have resolved. And it's very important to recognize that period when you need to add dextrose to your IV fluids so that you can still reverse your acidosis without making your patients hypoglycemic. And that point usually happens when your glucose on your insulin infusion drops to about the 250-300 range. When you hit 250 to 300, you want to change your fluid management, and what you want to do is you want to take what you're on, let's say you're on 0.09 normal saline at 250 an hour with 20 milliequivalents of KCl, then you're going to add D5W, so then you'll be on something like D5 normal saline plus 20 milliequivalents of KCl at 250 an hour. And what this does is it allows you to keep giving glucose, keep giving insulin, and reversing your acidosis, which is your main goal in DKA. Now, the second reason this is important is because you want to keep your sugars while you're on an insulin infusion above 200 or around 200, and this helps reduce the risk of cerebral edema, especially in kids. If your glucose gets too low and it gets below that 200 value, you increase your risk of having bad outcomes. Even though this is rare in adults, you want to make sure you can avoid it if possible. So again, when your sugars get to 250 to 300 on insulin drip, make sure you add D5W, and you want to keep your glucose once you're on D5W around 200 until you are off your insulin drip or infusion. Now let's move on to one of the most trickiest aspects of managing DKA, which is how exactly do you transition someone off your insulin infusion and onto a long-acting or basal insulin dose. And this just requires a little bit more math. I have not found any good studies that show that a particular method has better outcomes or evidence, but it's usually pretty straightforward. And what you want to do is you want to calculate, based on the amount of insulin given in your insulin infusion, you want to calculate your total daily dose of insulin for your particular patient. And once you know your total daily dose, you can figure out what your basal insulin should be. And the way you estimate your total daily dose, there's 3 different methods I've outlined for you guys here, but the simplest method is you take the last 6 hours of insulin used while on your insulin infusion. So you take the total of the last 6 hours and you multiply that by 4, and that'll give you your estimated total daily dose. So let's say we have a patient, in the last 6 hours they required 5 units, 6 units, 6 units, 5 units, 5 units, and 5 units an hour respectively of insulin. This adds up to roughly 32 units over the last 6 hours. You multiply that by 4. That's basically 120 units is your estimated total daily requirement. And once you have that, you just take half of that, and so you say your basal dose or your long-acting insulin you want to transition to is 60 units. So you can say give them 60 units of Lantus, and then while you're giving them this Lantus, because it takes 2 hours to start reaching your peak, you want to keep them on your infusion for your 2-hour period, and then after 2 hours of giving that, you can take them off your infusion. You can stop it. So you see here, this is the most straightforward way. Again, last 6 hours multiplied by 4. Another method you can use is you take the average hourly insulin in the last 6 hours and multiply that by 20. So if we use these values again, the average hourly amount of insulin we've given is about 5 units an hour. Multiply that by 20, we have about 100, and that's our total daily dose. And once we have our total daily dose, we take half of that, so we have 50 units as our basal dose. It's a quick way of doing it. And this, again, our goal is, it's not exactly 50 or 60, but we want to have a rough idea of what it is, and we're going to have to titrate it per patient. The final method here, what I like to call the Olympic method, is, I've never done this, but you can do this. You take the last 7 hours of your insulin doses, drop the highest 2, and take the remaining 5 and add them together, and then multiply that by 4. So in this particular patient, if I took out, I'm going to change colors here, the 2 highest doses were their 6 unit doses, so we take the remaining 5 unit doses, add them up, multiply by 4, and do the math, and basically gives you the same values. Okay. The last subject I want to move on to is HHS. And I'm just going to cover this really briefly before we run out of time. HHS is, of course, hyperglycemic hyperosmolar syndrome. Similar to DKA, what you're treating in HHS is not your hyperglycemia, but and something else entirely. What you're actually trying to do is you're trying to treat elevated plasma osmolarity, and usually by definition it's going to be greater than 320. In HHS, you do not have an acidosis. This is what kind of separates it from DKA. You will find that people, because of their really high osmolality levels, will have sometimes confusion and altered mental status, and about 10% of the time people may actually be in a coma, but that's not always the case. The hyperglycemia in HHS is really significantly higher. You can have glucose levels in the thousands, and you're going to have massive fluid deficits, much greater than DK, usually 8 to 10 liters, and you can calculate that out. The mainstay of treatment for HHS is fluids, and after giving fluids, of course, you start insulin infusion. And a lot of patients, fluids alone will significantly bring down your hyperglycemia, and your insulin infusion will do the rest. Your goal in HHS is to get a plasma osmolality less than 310. Once it's less than 310, you're out of HHS, and you should be better, and your people's mental status should improve, and so forth. Just like in DK, it's important to keep in mind that when you have a sugar level around 250 to 300 on your insulin infusion, you want to add glucose. You want to add D5W to your fluids. And again, why are you doing this? Well, in HHS, you're doing this because you may not have reached a plasma osmolality below 310, and so you need to add glucose to help keeping the fluids going. But the main reason is cerebral edema. Adding D5W is supposed to be protective to help reduce the risk of getting cerebral edema, and if you don't add D5W and hit this range, there is a chance that they may drop too rapidly and too precipitously, and you'll have that cerebral edema. And again, your hourly goal is about 50 to 80 grams of glucose a deciliter an hour. Initially, when you're giving lots of fluid, your glucose levels may drop a lot more rapidly, but once you reach that 250-300 range, you don't want to be going too far below, and you don't want to be reducing it faster than this. I hope this has been of value to you guys. Thank you so much for your time.